Let's dive straight into this high-stakes explainer. We're executing a strict clinical trap simulation, perfectly calibrated to help you secure that elusive 280-plus score. Look, whether you're navigating top-tier board assessments or you're literally standing in an acute clinical ward, you have got to be able to distinguish between a red, painful eye that needs immediate pressure reduction versus one that needs urgent inflammatory control. It is an absolute necessity, because a single pharmacologic misstep here, it doesn't just cost you points, it can permanently cost the patient their sight. So let's get into it.
Here's the agenda we'll be running through today. First, the pressure surge. Second, the inflammatory matrix. Third, the lethal pharmacologic crossover. And finally, number 4, we'll test it all with the master case.
All right, Module 1, the pressure surge, acute angle closure glaucoma.
Now, this pathology is strictly driven by the physical occlusion of the trabecular meshwork by the peripheral iris. You can think of it kind of like a massive plumbing disaster. Aqueous humor is constantly being produced in the eye, but in AACG, the drainage angle is physically blocked. This mechanical crisis catastrophically halts aqueous drainage, which leads to an immediate blinding spike in intraocular pressure. The fluid literally has nowhere to go, and your optic nerve just takes the absolute brunt of it.
Clinically, this is a massive emergency. Your patient is going to present with agonizing unilateral eye pain, headache, and severe nausea. They'll also frequently describe seeing halos around lights. And if you physically palpate the eye, the globe itself is going to feel rock hard, just due to all that trapped fluid. It's a highly distinct, unforgettable clinical signature.
So what triggers this? AACG is precipitated strictly by pupillary dilation. Picture a patient walking into a dark movie theater, maybe experiencing high stress, or taking anticholinergic or sympathomimetic drugs. You look at their eye and you see the absolute pathognomonic finding, a strictly mid-dilated, non-reactive pupil, usually accompanied by a completely steamy or hazy cornea. This pupillary dynamic is your definitive anchor. Do not forget it.
Because we're dealing with a physical, anatomical problem, your management mandates a very discreet two-step protocol. Step 1. You must drop the production of aqueous humor immediately. Lower the pressure first with agents like IV acetazolamide or topical beta blockers like timolol. Then, once that pressure actually drops, step 2 is non-negotiable. You absolutely must administer pilocarpine, which is a miotic agent. Pilocarpine constricts the pupil, physically pulling the iris away from the trabecular meshwork to release that anatomical blockade.
Okay, let's lock this in with our first clinical variance box. This isolates the red, painful eye based purely on these strictly defined pupillary dynamics. If you see a mid-dilated, fixed pupil with a hazy cornea, you are dealing with an immediate mechanical pressure crisis. Pressure reduction, followed by meiosis. Memorize this profile because we're about to look at its exact opposite.
Which brings us to Module 2, the inflammatory matrix, anterior uveitis.
Let's see how this builds into a really deceptive clinical mirror. Instead of a mechanical block, we're now looking at an inflammatory matrix. If you look at this diagnostic slit lamp signature, you'll actually see leukocytes floating right there in the anterior chamber. We call this cell and flare. You might even spot a hypopion, which is when those inflammatory white blood cells settle at the very bottom of the chamber. This signals severe anterior uveal tract inflammation.
Now, visually contrasting these two is exactly where the clinical mastery lies. A patient with uveitis presents with extreme photophobia. And unlike that mid-dilated pupil we just saw in AACG, the pupil here is strictly constricted, or miotic. Plus, it's often highly irregular. Why? Because of posterior synechiae. The inflamed iris essentially gets sticky and actually adheres directly to the anterior surface of the lens.
You also cannot discuss uveitis without mapping its systemic integration. This autoimmune inflammatory matrix is heavily linked to HLA-B27 seronegative spondyloarthropathies. You absolutely must actively associate this specific ocular presentation with systemic conditions like ankylosing spondylitis or reactive arthritis. This integration perfectly sets up our high-yield diagnostic trap, directly linking lower back pain or urethritis straight to the eye.
So, looking at our second clinical variance box, it isolates the red, painful eye, but this time it's tied to a strictly meiotic pupil and extreme photophobia. Because the underlying mechanism here is inflammatory adhesion and not mechanical pressure, it demands a completely 100% opposite therapeutic approach.
And that leads us right into Module 3, the lethal pharmacologic crossover, where we navigate inverse pharmacology. This right here is the absolute most dangerous territory in this explainer, and it's exactly where high-scoring clinicians separate themselves from the pack. The inverse pharmacology is strict.
As we established, AACG requires pilocarpine to constrict the pupil and open up the meshwork. But uveitis? Uveitis strictly mandates mydriatic agents like cyclopentolate or atropine. You have to forcefully dilate the pupil to break those inflammatory synechia and prevent the iris from permanently fusing to the lens.
Conversely, applying the wrong mechanism is catastrophic. Just look at this high contrast warning. If you give a uveitis patient pilocarpine, you will literally clamp their inflamed iris down onto the lens, violently worsening their synechia and causing permanent iris damage. On the flip side, giving atropine to an ASCG patient will fully dilate their pupil, completely sealing off the trabecular meshwork and causing instant, irreversible blindness. You literally cannot afford to mix these up.
All right, Module 4, the master case. Let's really test your deep integration of all this.
We're going to integrate these intricate mechanisms into a highly competitive clinical assessment blueprint. Here's the setup. We're testing a 40-year-old male with a history of lower back pain who presents with a severely red, painful right eye and intense sensitivity to light. The prompt embeds a very specific physical exam finding, a markedly constricted, irregular right pupil. This presentation is specifically engineered with that severe eye pain to heavily tempt you into immediately diagnosing a pressure surge like AACG.
But you have to maintain strict discipline. Map the lower back pain, which heavily suggests ankylosing spondylitis, and that myotic, irregular pupil directly to anterior uveitis. Looking at our strictly defined 5-option matrix, A, B, and C are high-yield glaucoma therapies. Pilocarpine, acetazolamide, and timolol are all traps designed to punish clinicians who stop thinking the second they read red, painful eye. You must actively bypass all of them to force the selection of D, cyclopentolate. This mydriatic agent is strictly required to break the synechia. And option E, observation, that's just a trap that guarantees permanent inflammatory damage.
So, what does this all actually mean for you? The mechanisms we've outlined today are absolute. Whether you're aiming for a top-tier board score or you're making critical decisions at the bedside, the red painful eye demands rigorous respect for anatomical and inflammatory pathways. In a high-stakes clinical environment, a single pharmacologic error literally separates rapid healing from irreversible blindness. So the ultimate question remains, will you look closely enough at the pupillary dynamics before you write that catastrophic order? Keep analyzing, keep integrating, and I'll catch you in the next explainer.